right, welcome to this presentation on the ARPKD registry, ARegPKD. My name is Max Liebau. I'm a pediatric nephrologist in Cologne in Germany. I'm currently serving as the head of the Center for Chronically Ill Children and the head of translational pediatric nephrology here in Cologne, and I'm a member of the Center for Molecular Medicine also at the University of Cologne. This is my conflict of interest. So this talk is going to be about autosomal recessive polycystic kidney disease, and as you know, there's also an additional presentation by Lisa Gay Woodford that tells you all about the details of the clinical presentation of ARPKD. Just a very brief summary. It is a rare disease. There's one main gene that is affected, which is called PKHD1, encoding the protein fibrocystin. And ARPKD is characterized by massively enlarged kidneys due to ubiquitous microcysts that can be found throughout the kidney, as seen here on this pathology specimen or here on this MRI. In addition to the kidney, the liver is involved. Different from ADPKD, the phenotype of AR Pkd is characterized by congenital hepatic fibrosis, which is due to a developmental defect of the bile ducts. And clinically, the liver phenotype of AR Pkd is characterized by portal hypertension, and episodes of cholangitis, which are considered to be due to the bile duct dilatations. In addition to the hepatorenal disease, especially early in life, pulmonary hypoplasia may be a severe problem. Still, neonates are dying because of pulmonary hypoplasia in cases of ARPKD. And there's also pronounced hypertension in ARPKD, especially very early in life. Overall, there is a lot of clinical variability and there's no targeted therapy as to this point. And part of this is due to the fact that there are no well-established primary endpoints for clinical trials on ARPKD. So what's out there? There are treatment recommendations for ARPKD, and I've taken out these two. There was a very nice workshop a few years ago organized by Lisa, and there various experts came together to work on these specific consensus expert recommendations for the diagnosis and management of ARPKD. In addition, more recently, there's been work by the German NeoCyst Consortium with more broader general recommendations on perinatal cystic renal diseases. This has been very important work, but overall the recommendations still remain opinion-based and symptomatic. So there's still an urgent need to work on in this field. Therefore, some years ago, we said, okay, there's still so much to learn about ARPKD and the variability is very poorly understood. So therefore, we said, okay, we need to go back. We need to define and describe the phenotype even more in detail than it had been done up to this point. And what we wanted to go for was the evaluation of long-term clinical courses, the longitudinal clinical characterization, to identify then or to develop a deeply phenotyped cohort, and also to assess what people were doing in the centers, whether there was anything that would work nicely or maybe wouldn't work, and to identify clinical or biochemical risk markers. So we set up the registry study ARegPKD. This was initially supported by the German Pediatric Nephrology Society and still is supported by the GPN. And it was also made possible by the collaboration with the European Escape Network of Pediatric Nephrologists with the support of the German PKD Foundation. Already at the very beginning, there's been a close collaboration with initiatives both in the US and in the UK. And the registry is completely publicly funded with support, again, from the German PKD Foundation. And in the meantime, it's also supported by various international societies and consortia, and receives funding from the German Federal Ministry for Education and Research. Okay, the key inclusion criterion is autosomal recessive polycystic kidney disease of any age as clinically diagnosed, and the key exclusion criterion is proof of any other cystic kidney disease, for example, through genetics. You know that there are phenocopies of ARPKD, for example, HNF1 beta variants, and if a patient was included in ARegPKD after the clinical diagnosis of ARPKD, but then later on turns out to suffer from a different disorder genetically, then obviously he or she is taken out of the registry. So what do we do? How do we follow these patients? We ask for general characteristics in a basic data set. This includes family history, etc. And then there is retrospective data entry, which is possible, but there's also prospective data entry. And we ask for about one visit per year. And during these visits, we ask for the development of clinical markers, kidney function lab findings, sonomorphological markers, etc. And for a subset of patients, we started collecting biosamples. As this is a registry study, there obviously it is very important to assure data quality. We've approached this through various ways. One is the obligatory data entry for diagnosis defining questions. There are automated plausibility checks. We have a defined data validation plan. Some things are just not possible. You cannot have undergone bilateral nephrectomy and not be on any kind of kidney replacement therapy. So these kinds of things are automatically checked, and then the data is regularly reviewed by the study coordinators, and queries are sent as needed. As already pointed out, there is a collaboration with the important observational studies both in the US and in the UK. So where are we right now? We have 126 centers in 31 countries that have registered for ARegPKD, most of them coming from Europe or European neighboring countries. As of May 2021, we have included 680 patients with 3,843 independent visits. If we briefly look at the cohort, there's equal distribution of male and female patients, and most of these patients come from pediatric centers and have been diagnosed either prenatally or in the first year of life. And the current age, this is when we had 600 patients. The current age covers all age ranges in the pediatric field, but we do see some young adults with ARPKD, and obviously the young adults are very, very important newly developing subgroup of patients with ARPKD. So let's look at some of the data. This is the Kaplan-Meier estimation for kidney survival. What you can see is that there's this group of patients that very rapidly loses kidney function. So that very rapidly requires start of a kidney replacement therapy. And these are obviously the patients that we all think about when having the classical picture of ARPKD in our mind. Then afterwards, there seems to be a continuous progression to kidney replacement therapy in this cohort, and we end up with about 50% kidney survival by the age of 20, which fits to previous observations from smaller cohorts, which also means that we haven't improved a lot in the way we treat these patients. So one of the key questions to the registry is, can we identify a high-risk profile for disease progression? So could we identify a group of patients that could also benefit from intervention and from being part of a clinical trial? As ARPKD is a genetic disorder, the obvious question would be to ask, are there genotype-phenotype correlations? And for ARPKD, it's been known for a very long time that patients with two truncating variants show severe phenotypes. Indeed, it has been thought for a long time that these patients, that two truncating variants would not be compatible with life. However, over the past years, we and others have identified patients with biallelic null variants. But to look a bit more in detail at potential genotype-phenotype correlations, we recently teamed up with Human Genetics in Aachen here in Germany, who have a very long tradition of looking at genetics of patients with ARPKD. And both from the Aachen cohort and from ARegPKD, we identified 304 ARPKD patients with at least one variant of ACMG class 3 or more, so at least one variant classified as either pathogenic, likely pathogenic, or as a variant of unknown clinical significance. And in this analysis, we looked at patients surviving the neonatal period. So this is on the left-hand side, just as a reminder, the protein that we look at, fibrocystin, is a very large protein with almost 450 kD, with a single transmembrane domain, a very large extracellular part, and a very small cytoplasmic tail. So any truncating variant affecting the extracellular part is considered to result in a null function of the protein. So what we did in this study is we first looked at the localization of the different variants, and that fits to previous work by other groups. And what you can see is that there's one variant that is a bit more common, but apart from that, here you can see all the variants that we found at least 3 times, and they are all distributed throughout the extracellular part of the protein. We then also set up a new classification for this protein, a new classification in 4 subgroups of the protein. And we did so by looking at the distribution of exons, at the distribution of functional domains of the protein, and of the previously published data on the localization of variants. And we chose to just choose 4 different sections of the protein because we were looking for a potential classification that would be clinically applicable in daily life. And we will come to that in a few slides. So the first question was, if you look at the ACMG criteria, will it be helpful to stratify patients concerning their phenotypes? And what we see here is that we've classified patients according to ACMG in 3 groups, either confirmed, probable, or unknown, where confirmed means that these patients had at least 2 variants of at least ACMG class 4. Probable means at least 2 variants, with one variant being at least ACMG class 4, and unknown means 2 PKHD1 variants of ACMG class 3, or a single variant of ACMG class 3 or higher. And what we can see is that for the kidney phenotype, this is again the time without kidney replacement therapy. There's no huge difference between the 3 groups. Now for the liver, we chose to use 2 different classifications, and this is what you can see here. We chose as one classification signs of portal hypertension, and that includes, for example, thrombocytopenia, splenomegaly, etc. And we also choose to use a classification that we call time without substantial hepatic complications, and this is the time without transplant, without variceal bleeding, without the need of surgical intervention for polysystemic shunting, like TIPS, etc. And overall, there was no huge difference between these 3 groups in the liver disease. We then went on and looked at the type of variant. Here we compared patients with 2 null variants with the patients with 2 missense variants, a null and a missense variants, a group that we called others, and patients with just a single variant. And what we see is that for the kidney phenotype, and fitting to the previously published data, those patients with biallelic null variants do much worse than all the other groups. And among the other groups, we did not find a huge difference. Again, looking at the liver phenotype, we again found that patients with biallelic variants did worse than all the other groups, and all the other groups did not show major differences. And below here you can see that these were substantial numbers for such a rare disease. So again, we do confirm that patients with biallelic null variants show a more severe phenotype, but we also see that at least some of these patients can nowadays survive. We then went on and used the classification that I previously mentioned. Just as a reminder, again, we have these 4 sections of the protein, these 4 parts, and we used it and classified patients that either had 2 missense variant in one of these 4 areas, or a null variant and a missense variant in this area, and pooled these patients. For the combination of the null and the missense variants, we speculated that the weaker genotype would define the phenotype of the disease. And what we see here is that for the renal phenotype, indeed, there is one group of patients here in this second part of the protein that does not seem to progress as rapidly to kidney failure, to chronic kidney failure, as the other groups. For the liver phenotype, we see something different. We see that progression to signs of portal hypertension, or progression to substantial hepatic complications, is indeed more rapid in the group of patients that have either 2 missense variants in this area, or a truncating variant and a missense variant in this area. So from this data, we would conclude that missense variants affecting this C-terminal part of the protein are associated with poorer hepatic prognosis. And the data may also explain some of the variability that has frequently been described between the kidney phenotype and the liver phenotype in ARPKD. just a bit more in detail, we then went on and looked at the specific domains of the protein, and I want to keep this very short. But what we do see is that one of the domains, the G8 domain, seems to be relevant for liver disease in ARPKD, and we're currently following up on this in basic science approaches. One of the reviewers then asked us about specific conditions in patients with late diagnosis. It's very hard to say from this data. What we do see is that we didn't find a patient with biallelic null variants, but we did find both null-mis and mis-mis combinations. And again, we found these variants in all parts of the protein. Also affecting the cytoplasmic tail. In this figure, we show all of the variants that are found in this subgroup. In the one I previously showed you, we had just included the variants that were found at least 3 times. So genetics is very good and very helpful, and obviously very important for PKD and PKD research. But are there any ways to obtain easy, clinical, straightforward data that could be cheaper on the one hand, but also more rapidly available? Here we looked at risk factors of early dialysis dependency in ARPKD in one of the first papers coming from the registry. And what we did in this study is that we compared the clinical findings of prenatal information, perinatal information, and postnatal information of 36 patients that started dialysis in the first year of life, and we compared them to about 350 ARPKD patients that did not require dialysis in the first year of life. And there were some markers that were expected. So oligoanhydramnios was much more frequently seen in patients with early dialysis, but there were also surprising findings like APGAR scores that hadn't been looked at in detail before. From this univariate analysis, we then went on to multivariate Cox model, and here we found that oligoanhydramnios had a hazard ratio of 4.4, 4.5 for the need of renal replacement therapy in the first year of life, and also assisted breathing showed a very high hazard ratio. Also, the documentation of prenatally enlarged kidneys showed a hazard ratio of above 3. And we then went on to the next step and looked at the predicted probabilities for dialysis or renal replacement therapy within the first 12 and then afterwards in the first 36 months of life after birth. And what we do see is that that among ARPKD patients, there is a gradual increase of the probability depending on just 3 easy to obtain clinical markers. So in patients who had just enlarged kidneys or just the documentation of renal cysts, the probability was lower than in patients who had the documentation of both enlarged kidneys and renal cysts. But the stronger marker was oligoanhydramnios. And then in patients with oligoanhydramnios and either enlarged kidneys or renal cysts, the probability again went up. And in patients with all 3 markers, the probability for dialysis in the first 12 months was highest, reaching up to 1/3 of the patients. Also meaning that 2/3 of these patients did not require, would not require dialysis in the first 12 months. So antenatal sonographic detection that is widely available, the detection of kidney enlargement, of renal cysts and oligo or anhydramnios may help to estimate the risk for early dialysis dependency in ARPKD, and may also help to identify a first high-risk cohort, for example, for clinical trials. How about additional markers? How about TKV in autosomal recessive polycystic kidney disease? You're all aware of the status or the important role of TKV in ADPKD. Now, for ARPKD, things are slightly different, and part of it is that that it's been described over again that kidneys do not show the same growth pattern as an ADPKD. So we looked at our data a bit more in detail, and what we started looking at was the average pole-to-pole length as determined by ultrasound in 372 patients. And what we see is that the average pole-to-pole length in ARPKD patients increases with body height. However, if you look at it over time, looking at the age of patients at the visit, then the height-adjusted average pole-to-pole length actually decreases over time. And that fits to the publications of other groups that led to the conclusion that kidneys might actually shrink in ARPKD. So we then went to the next step and looked at the estimated total kidney volume in our cohort. And again, we see an increase of estimated total kidney volume with body height. But if we compare this now to over time with the different age of patients, we see that the height-adjusted estimated total kidney volume in this cohort remains rather stable. One of the questions that sometimes asked at this point is, okay, these kidneys are very big. Is ultrasound a good way of measuring these kidneys? So therefore we compared the pole-to-pole length of the right kidney with the left kidney, and we see a very good correlation. We also compared the estimated kidney volume of the right and the left kidney and see a good correlation. And we had a few patients that received both MRI or CT scans and ultrasound in a very short period of time. And amongst these, we do see a good correlation between these different methods. Just the very, very big ones may become a problem. How is this related to genetics in ARPKD? Again, the height-adjusted estimated total kidney volume was higher in patients with biallelic null variants. These kidneys were bigger than in the patients with biallelic missense variants. And importantly, we also compared the data to patients either with single variant or in patients that had not undergone genetic testing. And this is just always the first documented height-adjusted total kidney volume. And what we see is that also the patients without genetic testing had findings comparable to the patients with biallelic missense variants. When looking at the correlation of the height-adjusted estimated total kidney volume with kidney function, we find something that very much fits to previous reports, a loose inverse correlation between TKV and kidney function, and that seems to be the case throughout all different age ranges. The good thing about ARegPKD is that we can follow these patients longitudinally. And therefore, what we did is we looked at patients in the first 18 months of life, and we looked at their height-adjusted total kidney volumes, and then looked at the different development of kidney survival in the different quartiles of these subgroups, or of this subgroup. And what we see is that indeed patients with the highest height-adjusted estimated total kidney volume in the first 18 months of life show worse kidney survival than all the other three quartiles, and especially with the lowest quartile showing very good kidney survival. Why is that? Is it because they lose kidney function more rapidly? We therefore looked at the kidney function at the end of the first year of life and afterwards, and the course of these patients. And what we see is that, at least in our cohort, with the limited numbers and all the caveats of registry studies, etc., the patients that were in the highest quartile of height-adjusted TKV in the first 18 months of life showed the worst eGFR at the end of the first year, much worse than the other two. Whereas the slow body loss of eGFR between these groups did not differ dramatically over time. So early postnatal height-adjusted TKV may be another marker to estimate the risk for severe kidney disease in autosomal recessive polycystic kidney disease. And this is obviously, as you have seen, work that is currently under review, and we hope to get helpful comments for this work for follow-up. Right, so why would early treatment be so important? In the last slides, I've pretty much focused on these very young children, and why would it be so very important to find treatment for these kids? So one thing is that kidney transplant in most centers is not done in children with a body weight below 8 to 10 kilograms. And that in children with chronic kidney disease, that usually means that there are about 1 to 1.5 years of age. There's also evidence for worse 1-year graft survival after kidney transplant in children below 10 kilograms. And dialysis is possible, but it may be more complicated in these very young children. So we also looked a bit more specifically to peritoneal dialysis in young ARPKD patients. And there's sometimes the worry that peritoneal dialysis would not work well in patients with ARPKD. And therefore, we compared these patients to a group of patients with congenital nephrotic syndrome or congenital anomalies of the kidney and the urinary tract. To do this, we teamed up with the International Peritoneal Dialysis Network, and at this point, there were almost 3,000 patients enrolled in IPPN. Amongst these, we could identify 79 ARPKD patients with sufficient data sets, and we then matched them with CNS patients and with CACUT patients, and they were matched for age and time on peritoneal dialysis. And we then looked at the course of these patients and complications, etc. So to make a story very short, these were kids that were young, but at the baseline visits about 2.5 years of age. And what we then looked at was patient survival, which was a bit better in the CACUT group, as previously also found in other analyses. But we also looked at the PD technique survival. And there's, as you can see here in this Kaplan-Meier, there's absolutely no evidence for worse PD technique survival in ARPKD patients when comparing it to patients with congenital nephrotic syndrome or CACUT. Sometimes we're talking about the dialysis centers ask, oh, should we take out the kidney or should we take out both kidneys rapidly so that dialysis will be possible? And we've looked at potential consequences of this approach. What we did in this analysis, we set up 4 different groups of the ARegPKD cohort. We looked at patients who had received the bilateral nephrectomies within the first 3 months of life. We also looked at patients who had received bilateral nephrectomies in the year after, so in the month 4 to 15. We had a subgroup of patients with dialysis in the first 3 months of life, but without bilateral nephrectomies. And we had what we called a total kidney volume control, about the same sized kidneys, but without nephrectomies or dialysis. And overall, there were a few perinatal differences between these 4 groups. However, if we looked at complications afterwards, there were severe neurological complications, and I'm talking about ischemia, parenchymal defects, hypoxic encephalopathy, etc. in 12 out of 19 patients with very early bilateral nephrectomies, in 2 out of 9 with early bilateral nephrectomies, in 2 with very early dialysis, and in none of the TKV control patients. Obviously, this does not show a causal relationship. It is an association, but it still makes you made us become even more careful about very early bilateral nephrectomies in ARPKD patients, and these are the Kaplan-Meiers for these 4 groups. So very early bilateral nephrectomies in children with ARPKD may be associated with more neurological complications, and obviously much more work is needed to follow up on this. So, but it shows that ARPKD patients with severe kidney disease could benefit from early intervention to gain time. And here I show you that there's something moving on. There's actually a first trial that will be set up for children between the age of 28 days to less than 12 weeks of age with ARPKD, and the study will look if tolvaptan can delay dialysis in this group of patients. And there's also a study to see whether tolvaptan is safe in infants and children who at enrollment are at least 28 days and are suffering from ARPKD. And that's all online, so you can look at the details online. Just very, very briefly, how about the liver? I mainly focused on the kidney as a pediatric nephrologist, but how about the liver? Again, this is unpublished data on the liver survival, again with the classification that I previously introduced, signs of portal hypertension, so survival without signs of portal hypertension in our cohort, and survival without severe hepatic events shown up here. And as you can see, there is progressive there's evidence for progressive documentation of portal hypertension in these kids already during childhood and adolescence. We also had a look at young adults in one of our studies, and again here the liver was showed very prominent involvement, with thrombocytopenia and inhomogeneous liver parenchyma or splenomegaly in sonography finding. These are very, very small numbers because the numbers of young adults with ARPKD are very small. But it shows that liver disease is a very important aspect, especially for this subgroup of patients. So I've shown you some of the ARegPKD data. Obviously, there are limitations of the data. This is all real-world data entered by many different centers, and there are variable follow-up periods. There's partially missing data. There's data from different parts of the world, etc. The cohort is only partially genotyped, although the number overall still is quite big, but it's for sure a limitation that it's only partially genotyped. There are various kinds of biases. It's mainly tertiary pediatric nephrology centers in Europe. It may underrepresent liver disease. It may underrepresent patients with very severe disease because these kids may pass away very quickly and may not be approached by the centers. It may also underrepresent patients with not so severe disease because it's mainly tertiary centers. Some of the patients with a less pronounced phenotype may not be included, etc. So all this has to be kept in mind when looking at this registry study data. So here's the summary. There's emergent data from ARegPKD on the clinical causes of ARPKD patients, and some of these data may become helpful for the identification of ARPKD patients with a high-risk profile that could potentially benefit from early intervention or from the inclusion in clinical trials. Early inclusion early pharmacological intervention could be of particular relevance for kidney disease in ARPKD, and liver disease appears to become increasingly important as the disease progresses and as patients also make it into adulthood. So with that, I've come to an end, and I very briefly want to thank all the funding agencies, all the societies that support this work. I want to mention Kathleen Wogmeyer, who does a tremendous job when looking at the data of the registries, some of the collaborators, and most specifically all the participating sites and centers, especially of the German Pediatric Nephrology Association and the ESCAPE network. And with that, I've come to an end and look forward to the discussion at the PKD Summit.